You're watching Cetome TV. Knowledge is power.
I would just cut right into it with our usual approach. And our usual approach for discussing cancers is to discuss first how it's diagnosed, and then new advances in diagnosis, and then treatment related issues.
Okay. So tell us about prostate cancer. How is it diagnosed?
So, we'll go beyond the diagnosis. How it's classified for diagnosis is through something called the Gleason scale.
Okay.
And basically what the Gleason scale is, it's a series of biopsies are drawn.
Okay. And
then what the doctors do is they measure the grade of the, how much cancer is really in each biopsy sample, the percentage of the cancer in there and how invasive it is. And they measure that and they give it a scale of 1 to 5.
Okay.
And then what they do is they take 2 of those samples, the 2 highest samples that they have, and they add those numbers together and come up with what's called a Gleason number.
Okay.
And so a Gleason number of 6 and under means that you have a low chance of the disease progressing. 7 is intermediate, and then 8 and above is high.
Okay. So if I'm 6 and under, if you're 6 and under, they're going to suggest the watch and wait thing because it's there, but it's going to be slow is the concept.
Exactly. Yes.
Okay. 7, anybody's guess. Okay.
Intermediate.
Okay. All right.
I don't like the system.
Shocking that you're not happy with such an imprecise system.
It doesn't take into account many things, and you can have 2 of the samples, one being a 3 and one being a 4. You can have one being a 5 and one being a 1, and it'd still be normal. It'd still be low risk.
I see.
So it doesn't look at the molecular features. So it's and you don't know that you're getting a good representation of the most aggressive parts of the tumor. There's no way of proving that because they don't typically do any sort of imaging to really determine that.
I see. Right. So you mean before they actually take the
So
biopsy?
if you are going to base your diagnostics on a Gleason scale, then I think it's really important to have it from a prostate that's been removed, where you have all of the tissue to examine and you can look at it, rather than just doing punch biopsies.
Got it. Okay.
So there's a new criteria developed. I believe it was developed at the Mayo Clinic. It's called the Charted criteria, and it was based on a landmark trial.
Okay.
And it discusses what is a high volume disease. In other words, a disease that needs a treatment. Because as you know, with prostate cancer, a lot of patients are told to just watch and wait. So the Charted criteria basically says that if you have any visceral mets, such as metastasis in different organs outside of the prostate, and at least 4 or more bone metastasis sites, with at least 1 being out of the vertebrate or pelvis column.
Okay. This sounds like I'm already pretty advanced if I've got this going on.
So that's high volume disease.
So that's like I'm a stage 4 now with my metastases and all these things. So that's, okay. Wow. Hopefully it's caught before then.
Hopefully. So this brings us to imaging. The need for imaging, for proper imaging, because you don't know if you miss one of those mets, you could be high volume disease and not know it.
And the standard is we watch and wait if we don't know for sure.
CT.
Right. Which is why you're saying go get a PET CT because then nobody can tell you otherwise.
So typically with prostate cancer cells don't react to the standard PET CT very well. They do when they're very advanced, but the prostate is a very dense tissue, and it's hard to penetrate.
Okay.
So what this does is brings us to the PSMA.
Okay.
Targeted. And PSMA is a real advance in prostate cancer treatment.
Okay.
So what PSMA is, it's a prostate-specific membrane antigen.
Okay.
It's an antigen that is found in prostate cancer cells, and it's increased 1,000 to about 10,000 fold in cancer. And so what they do is they have all of these different radioactive isotopes that will identify this particular molecule, and then identify it throughout the body.
So no matter how dense it is,
exactly,
they can.
Yes.
They
and
can
outside of the prostate capsule too.
Wow.
Yeah.
Okay.
So common ones, they use a radioactive isotope called lutetium-177, and then there's gallium-68.
Mm.
But really, the technology on this is really amazing, because there's so many different isotopes that could be used for this, and so many different approaches. And
Specific to prostate cancer?
Yeah, specific to PSMA, not just prostate cancer.
Oh, really?
Yes.
Oh, wow.
Yes. So that one molecule that antigen, yes. In fact, from 2015 to 2017, I think there was like 1,115 studies on PSMA-based imaging.
Wow.
So it's really something. And these are clinical trials, obviously, studies. So obviously, it's a huge advancement for prostate cancer patients, and I recommend any prostate cancer patient to get on one of those trials. There's many different isotopes. Typically, imaging for prostate cancer, non-PSMA, is only about 25 to maybe 40% effective.
Okay.
So it's not very good.
Wait, did you say typical image?
Yeah, so like MRI or CTs and stuff like that.
Got it. Okay, so if your doctor says, "Oh, your MRI came back clear,"
don't
that's
believe
only
them.
25% accurate.
To 50, 25,
Okay.
yeah.
There's a lot of room for error.
Whereas PSMA started around 50% accuracy and go up from there.
Okay.
And they're all different. There's so many, and it's different from stage. Now, the one problem is that this antigen is expressed elsewhere in different tissues too. So there is a chance of false positives, and that is something that has plagued it. And everyone is looking for the perfect isotope right now. I don't know if they'll find that, but definitely, you can re-examine a false positivity and look at it and
you're
see.
not likely to get the same thing twice.
No.
Also, if you did have, I mean, this was invasive for the patient, I understand, but if you did have one of those PSMA PET CT scans, then at least even if there may be a false positive, as you're saying.
Yeah.
If you did have a biopsy at that point, you'd know.
Exactly.
Yeah.
So more than 95% of prostate cancers express this at a high level, at a very high level. So it's a very important component.
Yeah, I'd say.
Yes. So issues in prostate cancer right now, what should you be looking for? And this brings us back to tumor DNA sequencing.
Okay.
Very important issues. Two main ones are the TMPRSS2 ERG fusion protein. Now, this is a fusion between two different parts of the genome, two different genes. It involves the signaling and control region of one gene that splices with the control region or the expression area of another gene and turns it on. And so it stays on constantly and constantly signals growth. There's many different partners to TMPRSS2, which is a control region. I believe it's a control region. Sorry, I should double check that. I can't quite remember exactly if it's a control region.
You can double check and we'll post if you're not accurate there.
Okay, thank you. The usual partner is a gene called ERG.
Okay.
Now, this occurs in about 60% of prostate cancer, so it's definitely something to look for. It's not going to be in all of the tumors necessarily, so you want to do a liquid-based biopsy of this if you can. We do see it a lot in tumor-based biopsies, but there is a chance that it can develop elsewhere or not be in all of the tumors.
Okay.
It's involved in androgen signaling, so it regulates androgen signaling.
And tell us, for those of us who aren't you, what does that mean, androgen signaling?
Androgen is basically the androgen receptor, and that's what drives prostate cancer.
Okay.
It's like the ER, the estrogen receptor in breast cancer.
Okay.
It's the equivalent.
Right. Okay.
One thing interesting, though, that a lot of people don't know, there's been a few studies that show that when you do have this fusion gene, this TMPRSS2 fusion gene, number one, it's a negative prognostic feature. So you want to know if you have it, because then it will indicate whether you get whether you get more aggressive treatment or not.
Okay.
One of the things it does do is it creates a sensitivity to a drug called docetaxel, which is used for prostate cancer, but is not that effective in most cases. So when these patients with this fusion protein get docetaxel, they have a much better response than people who don't have that.
Okay.
So it's a negative prognostic feature that can be a positive prognostic feature with the right drug, like many of them.
Right. Hence, like we were talking about breast cancer earlier, right? That there's certain of those subtypes that really make a difference to how well your treatment will work out.
Yes.
Okay.
So the other one you want to look for is the androgen V7 alternate splicing variant.
You guys making notes about all this stuff? Oh my goodness. Androgen V7 splicing variant.
Yeah, so this is just basically an incomplete form of the androgen receptor.
Okie doke.
So androgen receptors on chromosome X, as you probably know or assume. And so in this particular case, what happens, first I'll give you a bit of a background on gene structure. So with gene structure, you have the component of the gene that is involved in its function. And it's going to have many different regions called domains. And each domain is going to bind with a different protein or a different DNA or do something different. You'll have different domains of every gene. And then what you have in this particular case is something called the ligand binding domain. And the ligand binding domain is a ligand is basically anything that triggers a receptor.
Okay.
So the receptor is on the outside of the cell. And when it gets triggered by the ligand, it creates a signaling cascade that creates, different changes, whether it's growth and metastasis or, inhibiting growth and metastasis, whatever the function is. So with the androgen receptor, when it gets triggered by the ligand, which is testosterone or androgens, it causes growth and metastasis.
Okay, right.
So the problem with this ARV7 is it is broken off the ligand binding domain. So if you look at a cell, a simple way of a ligand binding or a receptor is it's going to have this little region. Here's the cell surface, and here's the receptor sticking up, and then the ligand comes in, binds, and it closes up and creates a signaling cascade.
Okay.
In the ARV7 variant, it is missing the ligand binding domain.
Oh. So there's nothing for it to attach to.
Nothing for it to attach to, but what that means is it signals independently without testosterone.
Just hanging out there, signaling away.
Signaling away. It doesn't need that ligand to signal.
Uh-oh.
So it's a problem.
So that makes what happen then? Now it's signaling all
signaling
by itself.
without the presence of testosterone.
Yes,
so that makes you resistant to anti-testosterone treatment. Androgen deprivation is a standard treatment for prostate cancer.
Oh, okay. I didn't know that.
But you don't have to worry about it.
I have not. I do admit I haven't spent much time learning about prostate cancer for that reason. So one of the main standard cancers or treatments for prostate cancer is to reduce the amount of testosterone in your body, basically.
Androgen,
Okay, androgen. Right. And so if you have this androgen V7 splicing variant, what should you do?
Well, it's a bad prognostic feature. This is why you need to get sequencing to find out if you have it or not.
Okay, got it. Without the tumor
because that means
tissue
that means
sequencing.
androgen deprivation therapy, ADT as they call it, the standard treatment is not going to be very effective for you.
Right. And the problem with that, aside from not very effective, is that a lot of times in standard care, there's a long period between when you start your treatment and when they actually look to see if it's working.
You'll find out, it didn't work. Oh, by the way, you have the ARV7.
Yeah.
Now, we've also discovered there's another variant called the ARV9.
Okay. Is this new?
Yeah, it's
discovery?
relatively new. It's similar to the ARV7, and it's often co-expressed with the V7. So you see both of them.
All right.
So this is something you want to know. You want to test for
the V7 or the V9.
The ARV7, yeah.
Right.
And you also want to test for the TMP or SS2 fusion genes.
Right.
You want to know if you have that. And that just really outlines the importance of tumor DNA sequencing.
Okay. Yeah, exactly. And that first one that you mentioned is kind of a mouthful, TMPRSS2.
Yes.
Fusion protein.
Yes, it's a fusion protein.
So that would also turn up in...
Fusion gene.
Fusion gene. And so that would also turn up in a genetic
Most
test.
genetic panels have that now.
Okay. Right. And again, if you do or don't have that happening, that's going to profoundly affect your treatment outcome.
So there's 2 reasons right there to get tumor DNA sequencing.
3 if you add the ARV9, unless I'm misunderstanding you.
Yeah, definitely, yes. Yes. Now, there's more reasons to get tumor DNA sequencing if you have prostate cancer. Number 1, and we see this a lot, is if you have a BRCA 1 or 2 mutation, or a BRCA mutation, that opens up the door for treatment with PARP inhibitors.
Okay.
And that can be very effective. So even if you do have these 2 negative prognostic features, if you have a BRCA mutation, you have a treatment that's going to override those negative prognostic features.
Okay,
you have a targeted therapy now.
You're heading into a territory that I think is important to just acknowledge, which is that BRCA is considered a breast cancer gene, right? Rightly or wrongly, that's what it's considered.
Right. Yeah.
So if you're being treated in the standard way, where your cancer is being diagnosed and treated based on the location, your doctor won't even necessarily be looking to see if you have something like a BRCA gene problem, right? But it shows up often enough.
We see it quite a bit.
Right.
Another set of mutations are PTEN loss. PTEN is a tumor suppressor gene. And then also PIK signaling pathway mutations. Those can open the door for different targeted therapies, mTOR inhibitors, and so on. More importantly, a lot of research is looking at the PIK3CA mutations. It's called the P110 alpha, and there's a bunch of drugs that target that are actually quite effective in prostate cancer.
Okay, so that's 3. So in addition to the androgen V7 and V9 and that TNPR,
those are negative prognostic features. These are targeted therapy options.
Okay.
Although obviously the TMP fusion proteins can be a targeted option because they indicate whether docetaxel will work.
That's where I was going.
So it's not really a targeted therapy per se.
Understand.
It can indicate a treatment.
Okay, so you're kind of segmenting. So you've kind of moved on from those
prognostic features to targeted therapies.
Got it. Okay, and there's 3 different things you've talked about so far: the BRCA, the PTEN, and the PIK3CA.
Yes.
Okay.
Now there's another one called AKT mutations.
Okay, and what is that?
That's another signaling pathway mutation.
Okay.
There's a new drug. There's a specific mutation called the E17K. That was one of the original ones they found, but there's actually quite a few different possible mutations you can have. And there's a new drug called ipatasertib. Ipatasertib. That's it. Yes. It's hard for me to remember all of these. It's a tyrosine kinase inhibitor.
Okay. That we can say.
And it's quite effective in patients that have AKT mutated prostate cancers, regardless of whether they have those negative prognostic features.
Ooh, that's plus. That's a plus.
Yeah.
Yeah. Okay. Now, could you just back up the bus a little? Forgive me, I was taking furious notes here. I might have missed this, but would you just, even for my sake, just tell us again, what is a signaling pathway?
It's just the genetics of the tumor.
Like how because you're talking about P10 and PI3.
Yeah, these are genes that are involved in cancer, that are altered in cancers.
Okay, and they will either like signaling pathway. My brain's trying to understand this. They what?
Ooh, I'm not sure where to start with this.
Sorry, I just want to make sure everyone understands.
There are genetic mutations that cause cancer. To get into it, we'd have to start with the very, very basics, and we need a few episodes for that.
Okay. I'll let you know when we have Alex doing the basics for us here. But for now, okay, so P10, PI3, PIK.
Gene mutations cause cancer.
Got it.
That's
where we want to start. Okay, fine.
All
right. And clearly what you're telling us already today is there's a lot of genes that could be involved in your prostate cancer.
Which is why we do tumor DNA sequencing.
Right, because they really will make a difference.
What are we up to now for genetics, for genes?
7. Oh, you mean, I thought you were talking for
How many genes do we sequence now typically?
About 550.
Okay, so there's about 550 different genes we'll look at through all cancers.
All right, but we're not going to talk about them all today.
These are just a few examples. We see all kinds. We see graph. These are just the common new players that I wanted to go over today for prostate cancer that have clinical trials and drugs and are effective treatments.
Okay, so very beneficial for you to know about, because there's
doesn't mean that there's mutations where you can use an off-label drug such as BRAF from melanoma or something. That's definitely an option too. We see that all the time. These are the common ones that are associated with prostate cancers, and that have drugs and clinical trials and data. The ones you want to look for if you have prostate cancer.
Okay. Thank you for that. All right. What else do you want us to know?
So I just wanted to briefly talk, although we're running out of time, and I don't think we're going to be able to get to this.
It's okay. We'll be
I wanted to briefly talk about some of the new drugs. This is amazing classes of new drugs.
Okay.
So in combination with androgen deprivation therapy, which is a typical approach, there's a class of drugs called androgen receptor antagonists.
Okay.
And so what they do is they antagonize the androgen receptor.
And they make it absorb? They make it go to work? Is that what they do?
No, they do the opposite.
Oh.
Remember, the androgen receptor binds its ligand and then signals.
Yeah, but I thought
we
it was
don't want
not
it to
able
do
to.
that.
Oh, we don't want it to.
No.
Okay.
And when you have the ARV7, then what happens is it does it by itself without the testosterone or the androgen.
I see.
So what we're doing is we're preventing that receptor from working properly with these drugs, and that's why they're called antagonists. They antagonize the receptor.
Okay.
So there's 3 FDA-approved ones for prostate cancer right now. They're all approved for metastatic hormone-sensitive prostate cancer.
Okay, which means?
That it's still responding to hormones.
Okay.
Or anti-hormone therapy. Still responding to ADT.
Okay.
Somewhat.
All right.
But it's metastatic.
And how would they be telling that it's still responding? Typically, in standard
the PSA
care?
typically goes down. Yeah.
Okay. Thank you.
Or remains stable.
Okay.
But at diagnosis, you have a lot of tumors all over your body. So you're stage 4 right off the bat. So there's 3 of them approved. One of them, the oldest one, is called abiraterone. It works really well. There's a trial called the Latitude trial.
Okay.
And it showed that in these prostate cancer patients, there was a overall survival of 53.3 months versus 36 months just for ADT alone.
And these are advanced cases, or this is?
This is all stage 4, metastatic hormone-sensitive prostate cancer.
Okay.
This is what we're talking about, this group of drugs.
It is what you're talking about. I'm just not as knowledgeable as you, so you have to bear with me. Okay, go ahead.
So also for metastatic hormone-sensitive prostate cancer, there's another drug called enzalutamide. That was done in the ARCHES trial.
How current is this?
It's relatively current.
Okay.
Now, this was a group of patients that was very sick. 18% of these patients had already had like 6 cycles of docetaxel and were still very, very sick and not doing very well. So, they gave them this drug. In this trial, the progression-free survival was not reached for the people taking enzalutamide plus the ADT. And for the ADT alone, it was 19.4 months. And the overall survival, it was, I think, I can't quite remember. It was, I don't have the time for it, but it was like 20% more patients on this trial taking enzalutamide had a great response.
Okay.
Compared to only 63%.
Oh, okay. So with that first one that you mentioned before I interrupted you with my question, people got an extra 2 years or so, and they were already stage 4, quite advanced. And this one, there's also quite a significant
huge difference,
improvement.
Yes.
Wow.
Much better than abiraterone.
Wow.
And then there's apalutamide,
okay.
which was showed in the Titan 3 trial. So in this particular one, once again, this is metastatic hormone-sensitive prostate cancer.
Okay.
These are all FDA-approved drugs, so they are used in regular practice. Whether they're at your hospital or not now is another issue. There was a 52% reduction in death or progression with this drug combined with ADT.
Okay.
And progression-free survival for this trial, because it's not over, I believe, was not reached in the combination group, and was 22.1 months for the androgen deprivation alone.
Okay. All right. So they're still waiting. Actually,
Yeah,
they need more
most
time.
of these trials are. Yeah. So
Okay.
these are.
That's how new they are.
Yes, they're very
Right.
new drugs. Yeah.
Okay, but years of life being added for people.
Right. So one of the common things that happens in prostate cancer is patients stop responding to ADT. And whether it's because of the two prognostic features I discussed earlier,
Mm-hmm.
whether it's that receptor that doesn't need ligand binding to signal,
Mm-hmm.
there's many different factors there. But eventually, most prostate cancer patients will become what they call castration resistant.
Mm.
And so by then, there's not really a lot of treatments apart from chemotherapy, which is not very effective there.
But as you're saying, and I think this is important to note, or at least clarify, that data may simply be because it's not standard to use the genetic testing beforehand to make sure you've appropriately stratified people.
Yes.
They're not necessarily
stratified.
They're not stratified. They're not gay. So that statistic may not be accurate when cancer is treated in a precision oncology way.
Of course.
Right.
This is standard treatment.
Okay.
All of these trials
want to say that
are
because it's important
specific.
to understand that the huge impact that one piece like genetic testing can have.
Definitely. Yeah. All of these are specific. All of the data is specific to standard treatment.
Okay.
All clinical trials compare their data to standard treatment.
So that, and what we see is the results from precision oncology are always well and beyond standard care. So that's even better news for you with these new FDA approved treatments. Wow.
So the final drug I want to talk about is showing evidence for response in castration-resistant prostate cancer. So this is a huge gain in treatment. So the drug is called darolutamide. It's once again an AR antagonist, but it is the one that we believe is going to be the best drug.
Okay.
So it was originally approved by the FDA in what was called the Aronson's trial. And it showed a huge benefit for hormone-sensitive prostate cancer patients when combined with ADT and docetaxel. So they used all three drugs there. And huge benefit. And there's two trials right now, one called the ARIDES and the ARA4. And they're actually looking at metastatic castrate-resistant prostate cancer. So these are patients that are resistant to ADT therapy.
In case you're wanting to check this out at home, ARADES is ARADES, and ARA4 is ARAFOR.
Yes, thanks.
You're welcome.
So this is a better drug than the other AR antagonists. It's one of the best drugs. It's got increased efficacy, so it works better at a lower dose.
Oh, that's good.
Importantly, it works on those androgen receptor mutants. So the negative prognostic features, the ARV7 and the ARV9. There's many different mutations that you can have in the androgen receptor. Those are just two that we discussed. But this drug works on those. So it's one of the only drugs that works on those.
Okay, that's
so
exciting.
It has a different mechanism for binding the receptor. So if the ligand binding domain is missing from the receptor, this drug will still work.
Wow.
Whereas the other three won't. And that's probably why it works on castration-resistant prostate cancer as well as hormone sensitive.
Right. And that's darolutamide.
Darolutamide, yeah.
Okay.
Now, one of the big problems with any AR agonist and hormone therapy is it can cause a lot of problems, what we call CNS activity. And so this can be strokes, strokes and seizures and stuff can happen from this, So
from this new drug you're talking about?
No.
Oh, sorry.
I'm saying from prostate cancer treatment, ADT.
Okay. Okay, from the standard treatment.
From the standard treatment.
Okay. This is where my lack of knowledge of this particular type of cancer is really showing.
It's a very complicated thing.
Okay.
Don't worry about that. This is this is so new. So
okay, but the androgen deprivation therapy, which is a common approach, has these nasty side effects to the central nervous system.
Yes. When combined, especially with these AR antagonists.
Okay. All right. So what are we going to do about that?
Well, most people just try to manage them with steroids. You don't really have a choice. It's either the disease progresses and you die quicker, or you try to deal with these side effects, and they can be seizures and strokes and things like that. So they're nasty side effects.
Yeah.
So you have to be well monitored.
Okay.
So
And
with darolutamide, it is a unique drug in the sense that it doesn't cross the blood-brain barrier. And that's what makes it so special, is because of that, it has totally reduced side effects compared to the other AR antagonists. And you don't have to worry about these seizures and
seriously?
things like that. Yes, this is a new drug. This is going to change all of this. So the AR antagonists have been around for a while, but this is the latest AR antagonist. Number one, doesn't have the side effects, the dangerous side effects. Number two, works better. Number three, works on androgen receptor mutants that the other ones don't work on. And number four, the most important thing is it also seems to work on castration-resistant prostate cancer.
Wow.
So it is the new drug.
The golden
New
child.
golden child, yes.
Sure. Just to have so many more benefits and so much less chance of those side effects.
Yes.
Wow.
Yes.
And longer survival.
Yes.
That's all good.
Yes.
So that's.
But we don't know the survival yet. The trials are still out. Two trials.
But it's already showing good results.
Yes.
And so that's the ARIDES or the ARA4 trials.
No, those are for metastatic castration resistant.
Okay.
And the Arisons was for hormone sensitive.
Okay. All right. So let's say my brother has just been diagnosed with prostate cancer. He's got all the markers that would be relevant. Would he be able at this point to ask his doctor for this darolutamide as part of his treatment? Or is
what
it
does he
still...
have?
Well, I don't know. I'm assuming he's got all the stuff.
We would have to look at his case.
Okay. What I'm trying to, right. So we need the genetic testing. We're back to that. You have to know.
Well, we'd need to know what his staging is. We'd need to know if he's castration resistant. We'd need to know if he has resistance mutations. As you say, looking at the...
So those are some important pieces of information.
Yeah, exactly.
Once you have that information, you can better assess which treatment would be best for someone.
Exactly.
Obviously.
We have to look at everything.
Right. That makes good
full
sense.
medical records
Okay.
review.
I guess what I was really trying to say is, given that this is such a new treatment and so incredibly beneficial, is that something that is accessible to?
Yes.
Okay. It is available.
It's an FDA approved.
Okay. Awesome. Good news. Because, why wouldn't we? Yeah.
Very much so.
All right. What else would you like us to know, if anything?
I think that's
prostate?
about it.
That's pretty much it?
Yeah. We've gone a bit over.
Okay, we have. We're starting to do that, aren't we? But this is really good information, Alex. Thank you.
Yeah, there's a lot of information here, and I apologize if a little bit was a little complicated.
Well, for me, but not necessarily for all the folks watching at home.
And to explain it in such a short period of time, we probably needed 2 sessions for this.
Well, let's remember that for next time.
Okay.
Or we can certainly do some more a little bit later on this particular topic. But this is excellent information and really inspiring.
It should be. For anyone with prostate cancer, be inspired.
There's a lot you can do.
There's so much going on right now. And spend the money on the genetic testing. Don't just do wait and see. Yeah. Definitely spend the money on genetic testing.
That's the thing. And then you just have the details about what's happening in your body, and it makes it so much easier to access all of these treatments that are going to be so much better than standard care for you, probably.
Yes.
Thank you for watching Ketome TV. Subscribe below and stay informed.